Hey, my name is John Croushorn. I'm one of the inventors of the Abdominal, Aortic, and Junctional Tourniquet. This is the package that it comes in. It's shrink wrapped, small weight and cube for the capabilities that it brings to the table. So this is the device on a mannequin. It's placed with a 18-inch ladder strap that slides under the patient's back or body, depending on the position. It is inserted until red meets red. It's tightened down, and then the ratchet allows it to be tightened further. This is over the abdominal placement site. This is tightened and then inflated. It's inflated until the gauge turns green, which is at 250 millimeters mercury pressure. 100% of the human subjects at the groin, abdomen, and axilla occluded at 230 millimeters of mercury pressure at maximum pressure, so 250 gets everybody. If the medic is too pumped up or the application keeps going, when it gets to red at 300, it will bleed back down with an automatic relief valve back to green. And that allows it to never be over-pressurized, which is also important when the casualty or patient's being evacuated. When we go up in altitude, ambient air pressure decreases, bladder pressure increases, and this controls the pressure. The Navy and the Army both studied it in an altitude chamber to show that the pressures do actually maintain according to the gauge, and the pressures in the gauge are actually the pressures on the patient's body. The indications are for groin or axilla junctional hemorrhage for up to 4 hours. The application in the mid-abdomen space is approved for up to 1 hour. It's the only truncal tourniquet that exists right now. And the ISR in 59th Med Wing in 2017 had 8 different studies that showed that it was equivalent to Zone 3 Reboa in the abdominal space, and it's the only one that will stop pelvic bleeding when applied at the abdominal site. So, grab the device over here. The device is made from high-density polyethylene that provides a more stable structure to put the device around the patient. Almost all the changes to the device since its original inception have been to try to stabilize the device so it doesn't rotate, move, or fall off the patient on inflation. The wedge-shaped bladder, the apex is controlled with a piece of shock cord that keeps it at midline so that when it's inflated it goes straight into the patient. There's a piece of non-slip material that helps it not move. The strap has been widened from 2 inches to 3 inches, which not only improves comfort and stability, but it reduces the pressure and force being applied to the soft tissues and muscle on the back around the patient. The ease of use of the ratcheting device opposed to the windlass that was on the original device is both faster and much simpler to use in a high-stress situation. I've put the device on 2 patients, both were junctional hemorrhage, groin and axilla. The groin wound was high in the leg. I could put 1 cat tourniquet over it. But once we began to resuscitate the patient, he began to bleed out of the hole. I could not put a 2nd cat tourniquet above, so we put the device over the isolated inguinal region, inflated it, and it provided hemorrhage control throughout the course of his resuscitation and transferred to a higher level capable of repairing the vascular injury, which happened to be a femoral artery transection at the point that he was shot. There was no collateral flow issue or resumption of bleeding from the hole during the device's inflation. Similarly, I had a patient that was shot in the upper arm. He had 2 holes through the axilla. He lost 6 centimeters of his axillary artery. The bullet did not penetrate the chest cavity. We applied it to the axillary region. When you do that, the way that you do that is the bladder is focused here. The strap wraps around the opposite shoulder and it's inflated. When the wedge-shaped bladder inflates on the chest cavity, it pushes force up the chest wall and actually occludes blood flow through the subclavian artery at the mid-clavicular level. So we can actually treat a full shoulder disarticulation injury or have anatomy that has been destroyed by trauma and still stop bleeding to the upper extremity, shoulder, and axillary region. The patient that I placed it on not only survived, but was able to keep his arm. He required several bypasses to reconstruct the vascular supply to the arm, but he did survive, and it was because of the device. The device stayed on for 28 minutes. Not a single drop of blood came out of the hole when it was applied. I even followed the patient up to the OR and saw the surgeon go in and ligate the subclavian artery, and you could see where it had been occluded at the mid-clavicular level. The device was studied in 2017, as I said, by the Institute for Surgical Research in 59th Med Wing and found equivalent to Zone 3 Reboa. It provides a unique tool that anybody in the field can use. So it does not require higher level of training or higher level of care to begin to reap the benefits of the advanced intervention of Reboa. It provides a bridging mechanism to take a casualty from point of wounding until they get to definitive surgical care and Reboa or other resuscitative surgical intervention. It's very quick to apply, very safe to apply, and it's now available by North American Rescue.